Welcome to the Australian Dental Council 2026 Explainer podcast.
Thank you. It's really great to be here.
So I want you, the listener, to just imagine waking up, looking in the mirror, and realizing that the very structure that allows you to speak, eat, and express emotion has been completely shattered.
Yeah, or, imagine a child born with the jaw structure so underdeveloped that just drawing a single breath while they sleep is a constant struggle.
Right, a dangerous struggle. And today, I am thrilled to welcome you to this custom-tailored deep dive into the hidden world of the surgeons who are tasked with putting human identity and essential function back together.
It's a critical space to explore. We're looking at a discipline that fundamentally challenges how we categorize healthcare, honestly.
Our mission today is an investigative clinical exploration into the basics and the profound importance of oral and maxillofacial surgery, or OMS.
And it really is a true bridge specialty. It operates at the absolute razor's edge of engineering, biology, and surgical precision.
Okay, let's unpack this, because when you say bridge, you aren't just talking about, like, a casual overlap between a dentist and a doctor, right?
No, not at all. It's much deeper than that.
To understand what an oral and maxillofacial surgeon actually is, I want you to imagine a highly complex, modern skyscraper. Now imagine a structural engineer who's responsible for the absolute integrity of the steel framework.
Right, making sure the whole building doesn't just collapse.
Exactly. But this specific engineer must also be an elite expert in the delicate plumbing and the intricate high-voltage electrical systems woven throughout that exact same framework.
Because if you reinforce a steel beam, but you accidentally sever the main electrical line, the building is still functionally dead.
Right. You can't just understand the walls. You have to understand every wire, every pipe, and how they dynamically interact.
That is exactly the kind of multidimensional thinking this field requires. If we connect this to the bigger picture, to use the precise clinical terminology, these surgeons are the experts of the craniomaxillofacial complex.
The craniomaxillofacial complex, that's a mouthful.
It is, but it encompasses the mouth, the jaws, the face, the skull, and the neck. It is an incredibly dense, high-stakes anatomical region.
I mean, you've got major blood vessels feeding the brain right there, right?
Exactly. Major blood vessels, critical cranial nerves controlling every facial movement, and the literal gateway to the human airway, all packed into a few square inches.
And what makes this deep dive so compelling is the history of how we've treated that specific region. Because we haven't always viewed the mouth and the body as a seamlessly connected system, have we?
No, we haven't. The history is actually quite revealing and, frankly, a bit illogical. If you look back at early medicine, going back centuries, you had barber surgeons.
Wait, literally barbers, like cutting hair.
Literally. These were people who would cut your hair and then, yank out an infected tooth. And over time, as science modernized, dentistry and medicine somehow evolved in completely separate silos.
Which is wild to think about now.
It is. Medical practitioners historically treated the oral cavity, the dentoalveolar complex, as if it were entirely separate from the rest of the human body. You had medical schools on one side of the campus and dental schools on the other.
But from the perspective of human anatomy, that division is entirely artificial.
Completely artificial. Your jaw doesn't know it's supposed to be dental. The blood vessels in your gums feed directly into the vascular superhighway of your head and neck.
Right. You wouldn't go to a toe doctor who completely ignores the vascular system of your leg.
Precisely. The mouth isn't some detachable accessory. It's the start of your digestive tract and your respiratory system.
And that's why OMS represents the philosophical and clinical reunification of dentistry and medicine. Which brings us to a major point of clarification for you listening.
Right, the environment where they work.
Exactly. When we talk about going to the dentist, you picture a clinic, a reclining chair, a bright light, maybe a waiting room with some magazines, but OMS surgeons are predominantly hospital-based.
Yeah, and that massive shift in environment comes down to their dual qualification and just the sheer physiological scale of what they're managing.
So they have to have 2 degrees.
In many jurisdictions, yes. In places like Australia and Aotearoa, New Zealand, an oral and maxillofacial surgeon is required to hold both a dental degree and a full medical degree.
Wow, so they are fully licensed medical doctors and dentists.
Exactly. Because they are medically trained physicians, they are equipped to manage acute care scenarios, the intense physiological trauma of major surgery, and complex multidisciplinary treatments.
Which obviously have to happen in an operating theater under general anesthesia, not just an outpatient clinic.
Exactly. You can't manage that level of trauma in a dental chair.
So Knowing where these specialists operate and why they bridge these two massive disciplines logically leads us to look at the foundational procedures. And wait, hold on. I have to push back here for a
Sure,
moment.
go ahead.
I'm looking at the core pillars in the source material, and the very first one is dental-alveolar surgery, and it lists extracting impacted wisdom teeth.
Right, that is a foundational procedure.
But I had my wisdom teeth pulled by my regular dentist in a chair while listening to the radio. Why on earth would pulling a tooth sometimes require a dual-qualified surgeon in a hospital?
It's a really vital distinction to make. It comes down to anatomical risk and systemic compromise. General dentists are perfectly equipped and highly skilled at handling simple extractions.
Sure, routine stuff.
Right. But OMS surgeons step in when the surgical risk escalates from routine to life-threatening. We're talking about severe, deeply impacted teeth whose roots are wrapped directly around the inferior alveolar nerve.
And that's the major nerve for the face.
Yes, it supplies sensation to your lower face. Sever that, and the patient has permanent facial numbness.
Oh, wow. So it's about navigating the landmines around the tooth.
Exactly. And beyond that, consider severe oral infections,
Yeah.
a condition like osteomyelitis, which is a deep infection of the jawbone.
Because of that vascular superhighway we mentioned earlier.
Right. A rotting tooth or an infected jawbone sits just inches from the brain. A localized oral infection can rapidly cross the fascial planes of the neck, restrict the airway, or travel upward to become a lethal brain abscess in just hours.
That is terrifying. So when a tooth stops being just a tooth and becomes a systemic threat, you need a physician in the room.
Exactly. They bring a deep understanding of general surgery, infectious disease, and anesthesiology to safely manage those crises.
Okay, that makes total sense. But their scope goes vastly beyond teeth. Let's look at the reconstructive side.
Oh, vastly beyond. The foundation also includes major corrective and reconstructive surgery. A prime example is orthognathic surgery.
Which is the functional realignment of the jaws, right?
Yes, literal realignment. If a patient has a severe skeletal discrepancy, say, their lower jaw grew significantly longer than their upper jaw, they physically cannot bite down.
Or chew, or maybe even close their lips properly.
Exactly. So the surgeon physically cuts the facial bones, repositions the entire jaw structure, and secures it with titanium plates to restore baseline function.
And reading the trauma scope in our sources, it's intense. We're talking about rebuilding faces after horrific car accidents or interpersonal violence.
Yes, reconstructing shattered cheekbones, orbital fractures, the delicate bones around the eye sockets, and comminuted mandibles.
A comminuted mandible means the jawbone isn't just broken, it's fragmented into multiple unstable pieces, right?
It's a puzzle. Reassembling that requires absolute mastery of three-dimensional facial anatomy. And then, in addition to trauma, they manage complex pathology and oncology.
So surgical management of oral cancers, complex jaw cysts that hollow out the bone, salivary gland diseases.
Yes, all of that. And finally, a foundational part of their work is congenital corrections, like cleft lip and palate repair.
But the sources also mention distraction osteogenesis. How does that actually work? It sounds like science fiction.
It kind of is. It's essentially tricking the human body into growing new, living bone out of thin air.
Wait, really?
Let's say a child is born with a severely underdeveloped lower jaw. The surgeon makes a precise cut in the bone and attaches a small mechanical device across the gap.
Okay, so they cut the bone in half.
Right. And after a few days of healing, a soft biological callus forms. Then, every single day, they turn a microscopic screw on the device to pull the bone fragments apart by exactly 1 millimeter.
Wow. So you stretch the healing tissue before it can harden.
Precisely. As you stretch that soft callus, the body panics and rushes calcium and blood vessels into the gap to heal what it thinks is a fracture.
That is incredible. So because you keep slowly pulling it apart day by day, you continuously generate new bone.
Yes, lengthening the jaw naturally without needing to harvest bone grafts from the patient's hip or ribs.
Here's where it gets really interesting for me. Because we've just listed the mechanics, right? The cutting, the moving, the stretching of bone.
Or physical execution.
But moving beyond that, we have to look at the physiological and psychological outcomes this has on a patient's lived experience. I like to think of it as the face as a window concept.
That's a profound way to frame it.
Because if you get a knee replacement, it changes your mobility, which is wonderful, but it's hidden under your clothing. Craniofacial surgery reconstructs the primary way a patient interfaces with the entire world.
The clinical literature strongly supports that dual impact. Let's look at the functional restoration first. These surgeries are not just about aesthetics.
Right. They restore baseline human physiological functions. like mastication.
Mastication, which is the mechanical ability to chew and process food, speech articulation, and crucially, respiration.
The breathing aspect is massive. The sources specifically mention targeted orthognathic surgeries for severe sleep apnea.
Yes, and the mechanism there is fascinating.
Yeah, because the airway is essentially a collapsible fleshy tube, right?
Right.
When a patient with a recessed jaw lies down, the base of their tongue falls back and literally crushes that tube.
Exactly, suffocating them dozens of times an hour. But by surgically cutting and advancing the jawbones forward, the surgeon physically pulls the attached tongue musculature forward with it.
Creating tension on the walls of the airway?
Right, propping it open like a tent so the patient can finally breathe through the night. It's a mechanical cure for a biological collapse.
And then you have the psychological component. The literature is very clear on this. Correcting severe congenital deformities or rebuilding a face after trauma goes far beyond vanity.
Absolutely. We use our faces to express every micro-emotion. It's how people recognize us.
Exactly. Rebuilding that reduces profound social stigma. It restores a patient's core identity and self-esteem. The surgeon restores not just the mouth and teeth, but the face and identity.
You really cannot separate the physical structure of the face from the psychological reality of the patient. And because the stakes are so phenomenally high, the OMS surgeon does not work in a silo.
Right, the interdisciplinary synergy. They are collaborators.
A major theme in their professional standards. They operate seamlessly alongside medical oncologists to plan cancer resections, with orthodontists to ensure teeth align after jaw surgery.
Along with plastic surgeons and neurosurgeons, right, because when you operate on the upper jaw or eye sockets, the brain is literally millimeters away.
Exactly. That requires intense interdisciplinary synergy.
So because this field requires such intense synergy with plastic surgery and orthodontics, I think we need to draw some strict clinical boundaries for you listening.
Yes, to avoid common misconceptions.
So let me ask a direct question. Are these professionals just overqualified dentists pulling teeth? Or are they essentially plastic surgeons for the jaw?
This raises an important question. First, as we established with the osteomyelitis and airway cases, they're absolutely not just pulling tooth.
Right, it's major surgery with systemic implications.
Yes, and regarding the comparison to plastic surgery, it is distinct from general plastic surgery, although there is certainly an aesthetic overlap.
But if they are reconstructing a face to look symmetrical, isn't that just plastic surgery?
Here's the critical differentiator. The OMS surgeon brings the meticulous, highly specific expertise of dental occlusion into the medical operating theater.
Occlusion meaning exactly how the upper and lower teeth meet and mesh together when you bite down.
Correct. Let's say a patient suffers trauma to the jaw. A surgeon without dental training might reconstruct that jawbone so it looks aesthetically perfect from the outside.
But the teeth might not line up.
Right. And if the dental occlusion is off by even a single millimeter, the functional result is a total failure.
Wait, why is a single millimeter so catastrophic?
Because your teeth are loaded with highly sensitive proprioceptors, sensory receptors that constantly communicate with your brain.
Oh, interesting. So your brain knows exactly where your bite should be.
Yes, if your bite is off by a millimeter, your brain senses that premature contact. It constantly signals your massive jaw muscles to grind and shift, endlessly searching for a comfortable resting place that no longer exists.
Which leads to what? Chronic pain.
Agonizing chronic headaches, shattered teeth from the immense grinding pressure, and total destruction of the jaw joint. The dual qualification allows the OMS surgeon to respect both the aesthetic macro form of the face and the microfunctional reality of the dental occlusion simultaneously.
That is a fascinating boundary. The marriage of microdental precision with macro-surgical reconstruction. Because a beautiful jaw is useless if it causes you chronic agony every time you close your mouth.
Exactly.
And speaking of the jaw joint, there's another boundary mentioned in the sources that I found really compelling, an ethical boundary regarding when they actually decide to operate.
Yes, the importance of conservative management. It's an absolute ethical pillar of the specialty. The mere presence of a condition doesn't mandate surgery.
Like temporomandibular joint or TMJ
Yeah.
disorders. That's the joint right in front of your ears, right? A lot of people have clicking or pain there.
Yes. And it's not just a simple door hinge, it's one of the most complex joints in the human body.
How so?
It's a dual articulating joint. When you open your mouth slightly, it rotates like a hinge. But to open wide to bite an apple, the ball of the joint actually has to slide completely out of its socket.
This slides out.
Yeah, it glides forward along the base of your skull, cushioned by a tiny cartilage disc, all while enduring hundreds of pounds of bite force every single day.
It's like a complex sliding suspension system on a heavy-duty truck. You wouldn't just take a scalpel to that suspension system at the first sign of a squeak.
Exactly. And while an OMS surgeon is fully qualified to perform complex open joint surgeries or even total prosthetic joint replacements, TMJ disorders are heavily managed through non-surgical conservative treatments first.
Like what? Splints?
Custom occlusal splints, which act as shock absorbers, specific physical therapies, and managing muscle tension. Surgery is the absolute last resort.
I think that restraint speaks volumes about the rigor of the profession. They have the skills to cut, but the medical wisdom to know when not to.
Absolutely.
So understanding these rigid boundaries leads us to a really practical question. If the margin of error for a jaw reconstruction is literally a millimeter, human hands and human eyes surely aren't enough anymore.
No, they really aren't.
So how are future surgeons physically calculating that in an operating room?
What's fascinating here is how rapidly digital adjunctive technologies have become routine. The days of making plaster molds of a patient's teeth and manually cutting them on a workbench are over.
So what do they use now?
We are looking at the routine integration of virtual surgical planning, or VSP, and 3D printed patient-specific implants.
So they literally practice the surgery in a highly accurate virtual space
Yeah.
before they ever touch the patient in the real world.
Exactly. They take high-resolution CT scans of the patient's skull and upload them into advanced software. The surgeon manipulates the complex on a monitor.
Calculating the exact bone movements required down to the fraction of a millimeter.
Yes, to ensure perfect airway opening and dental occlusion. Then, they 3D print custom titanium plates and surgical cutting guides that perfectly wrap around the contours of that specific patient's bone.
That is incredible. It takes the guesswork completely out of the equation.
It does. It allows for precision that was previously unattainable. It significantly reduces the hours spent under general anesthesia, and it dramatically improves patient outcomes.
So the modern curriculum requires them to be as comfortable with computer-aided design as they are with a scalpel.
Absolutely. But mastering the tech is only one piece of the puzzle. The institutional standards required to even practice this specialty are, frankly, staggering.
Right. Let's look at the pathway. And I want you listening to really let this timeline sink in.
It is a grueling, highly regulated pathway. In regions like Australia and New Zealand, achieving the fellowship in OMS requires an immense commitment. We're talking about acquiring a full dental degree,
Okay, that's 4 or 5 years.
then acquiring a full medical degree, then completing a minimum of a year in general surgery rotations in a hospital.
Just to even apply for the specialty training program.
Correct. Only after all of that do they undertake a highly competitive, rigorous 4-year residency program. From undergraduate entry to independent practice, this pathway can take up to 18 years.
18 years. That means someone who starts university at 18 isn't operating entirely independently until they're pushing 40.
It's true.
Is that level of gatekeeping actually necessary, or is it just institutional bloat?
It is absolutely necessary when you consider the stakes we've discussed. During that residency, they are evaluated continuously. They face foundation examinations in complex biomedical science, relentless work-based assessments of their operative skills.
And a final exit examination that tests their clinical decision-making under intense pressure.
Exactly. And the sources emphasize that they aren't just tested on cutting and suturing. They use an international framework called CAN-MEs.
Because they are dealing with humans, not just biological machines. What is the CAN-MEs framework?
It's a standard ensuring surgeons are well-rounded physicians. The central role is the medical expert, but they must equally master the roles of communicator, collaborator, leader, scholar, professional, and health advocate.
Especially regarding the trauma aspect of this job, right?
Yes. An OMS surgeon is frequently the primary doctor treating severe facial trauma from domestic abuse or catastrophic accidents. Being a health advocate, deeply trained in empathetic communication and cultural safety, is just as critical as their surgical technique.
Because you are treating a patient on the absolute worst day of their life.
Exactly.
So what does this all mean? If we step back and look at the entire landscape we've covered today, oral and maxillofacial surgery is the ultimate, long overdue reunification of dental and medical science.
It truly is.
It's a field that demands almost 2 decades of rigorous training just to enter, all to safely navigate the most functionally and psychologically complex real estate on the human body.
They aren't just fixing bones and pulling teeth.
No, they are reopening airways, curing severe infections, mechanically restoring the ability to eat and speak, and fundamentally giving people their identity back after trauma.
It's a profound clinical synergy, and it really leaves us with an important paradigm to consider for the future of healthcare.
What's that?
Well, as OMS continues to evolve with advanced micro-credentialing in areas like head and neck oncology, we have to ask a broader question. Will the strict historical divide between dentistry and medicine eventually become completely obsolete?
That's a huge question for regulatory bodies worldwide.
Right. If the mouth is so fundamentally connected to systemic health, if a tooth infection can become a brain abscess, will all future medical training eventually require a baseline mandatory understanding of dental science?
That is a massive shift to consider, and a perfect provocative thought to leave you with. If you want to explore the data, the surgical mechanisms, and the clinical frameworks underpinning this deep dive, we highly encourage you to review our foundational tests.
Yes, there's a lot of great literature out there.
You can dive deeper by reading the Journal of Oral and Maxillofacial Surgery, visiting aaoms.org, that is the American Association of Oral and Maxillofacial Surgeons, and exploring the International Journal of Oral and Maxillofacial Surgery.
Highly recommended reading.
For more insights into the future of reconstructive medicine, please subscribe and share this update.